Good afternoon, folks. You're listening to EBC Radio. This is 1170 AM. Program today is Heartbeat. Heartbeat is an educational program about your health, which airs on EBC Radio on the second and fourth Saturday of the month. I'm Dr. Dinesh Singal. I'm an interventional cardiologist. I'm the director of the catheterization laboratory at St. Peter's University Hospital and an attending at Robert Wood and Princeton, with practices in Somerset, Monroe, and East Brunswick. We've been bringing this show to you every second and fourth Saturday on the airwaves of EBC for the last several years. We hope you listen regularly and enjoy and learn from this program. We're also live now on YouTube. So if any of you are interested, hopefully this works today. You should be able to see us. The link is live.heartbeatradioshow.com, live.heartbeatradioshow.com. Today, I'm joined by Dr. Hossein Kazemi. Dr. Hossein Kazemi is an oncologist with a group in the Central Jersey area called Astra Cancer Care. And he'll be with us today discussing some of the newer therapeutics in cancer care. You know, cancer is a word which is very devastating to any family. Whenever somebody gets diagnosed with cancer, all kinds of images go through our head. Fortunately, technology and medicine and research has been progressing quite a bit, and not all cancers are as devastating as others. And proper preventive checkup and early diagnosis really goes a long way in helping people get the whole situation under control. So Dr. Kazemi is going to share with us some of the newer advancements. And with that, I welcome Dr. Kazemi to the show. Let me make sure everything is kind of working right. Dr. Kazemi, can you hear me?
Yes, I can hear you well. Thanks for having me. I'm excited to join you to talk about some of the great and very exciting advances that...
Hard time. Let me just make sure I have 1 second.
Oh, okay.
1 second. Let's make sure this is working. Can you hear me now or no?
I can hear you well. Can you hear me?
Okay. Yeah. Can you hear me now?
I can hear you very well.
Okay, very good. Yes, there was, again, this whole format on trying to broadcast live on YouTube has been somewhat of a challenge. So
sure,
I'm still kind of learning the controls which we have to work with. So very good. So thank you for joining us. And
thanks for having me.
Yeah, perfect. So, as you know, as we've discussed, let's lay the groundwork and we start from the very beginning. So tell us what cancer is. So for somebody who hear the word cancer, what's really happening in the body for us to call some diagnosis or a cell growth as cancer?
Sure. So, as you know, in our body, every day, our body makes many new cells. For example, bone marrow alone produces around 200 billion new cells per day. And usually this production is very tightly regulated. Body produces only what it needs to. And these cells each have a function. They are around as long as they are needed. And then they die or go away. In cancer, what really happens is that one cell goes rogue, goes out of control. So it starts making copies of its own, more than it's needed. And this production, this unregulated production starts causing problem for the body, either crowds out the space for normal cells or invades other organs and cause problem. And that's kind of a very general or simple view of what cancer is.
So you know what, I'm going to use an analogy just to make that point. I've used this before and somehow makes a lot of sense. So I tell people, think of it like a small piece of grass, and there is some weed growing in that grass.
Yeah.
And the weed can be very localized, or it can start spreading. And as it spreads, it takes over the normal grass. And I think similarly, you have normal tissue, you have these abnormal cells. And if they take up a lot of them and start spreading around, it's obviously not good news. If it's localized, it's something which is contained and can be, that can be pulled out. So
That's a very good analogy. Yes, exactly.
and so, historically, there have been a lot of treatments, and as we know, there's a lot of evolution in the options which we have. But broadly, I know they're kind of divided into three areas. So tell us the three broad areas of, unless I'm missing something, of treatment for cancer once the patient presents to you.
So historically, up until relatively recently, the treatment for cancer were divided into surgery, basically removing the tumor, radiation, killing these cells with high energy radiation, and chemotherapy. And today, since my focus in our group is focused on blood cancers, I wanted to focus more on treatments for blood cancer. So blood cancer, let me first give a small bit of an overview of blood itself and talk about different cancers of blood, and then what treatment options we have for that. We don't typically think of blood as an organ. In fact, it is a very complex and large organ. The cells in blood are produced in the bone marrow from stem cells that go through many divisions per day and maturate and differentiate to different cells that each have a function. And since these cells, by nature, they are supposed to travel in blood and go different places in blood, usually when we are dealing with a blood cancer, it's a little bit different from more common cancers like colon cancer or breast cancer. In colon cancer or breast cancer, a stage is very important, basically how localized or widespread the cancer is. In breast cancer, colon cancer, lung cancer, as people know, if we get it early stage, surgery plays a very important role. A lot of times surgery alone is enough. When it's a little bit more advanced, surgery plus radiation or chemo. And when it has a spread outside of the organ, then it's usually chemotherapy. These blood cancers, since by definition they are in the blood or lymph nodes, this staging and paradigm doesn't apply to them as the solid organs. A lot of times when patient is diagnosed with a lymphoma or leukemia, they always ask me, what stage do I have? And we do have a staging, but I always tell them it's not as important as the other organs, because surgery here doesn't really play a role because it's in the blood. It's far more widespread. So for blood cancers, the mainstay of the treatment used to be chemotherapy. Now these days we have targeted therapy and immunotherapy as well. And in some cases, radiation to be used in addition to chemo, basically to sort of potentiate the effect of chemo.
You're listening to Heartbeat. This is EBC Radio on 1170 AM. We are now also giving a live feed on YouTube. So if you close to a computer or your phone, you can go to live.heartbeatradioshow.com and you can watch us online. The phone number in the studio, if at any point you have a comment or a question, is 732-297-9886, 732-297-9886. I'm Dr. Dinesh Singal. I'm talking to Dr. Hossein Kazemi. He's an oncologist. So tell us the traditional chemotherapy, which was there for a long time. How does it work? And what are some of the limitations with the traditional chemotherapy, which we had or we still use?
So generally, for cancer, up until 10, 20 years ago, for blood cancers, we had chemotherapy that targeted rapidly dividing cells, because these cancer cells, they grow and divide faster than normal cells. So we practically used poisons, basically, that targets anything that grows rapidly. And it killed cancer cells more than it would kill normal cells. Now, I don't want to diss chemotherapy. It works, and still it plays a very important role. In fact, for many lymphomas, chemotherapy is able to cure them still, and it's a very vital part of our first-line treatments still. That being said, unfortunately, it's not enough for many patients. And also, it's not very easy to tolerate, especially for older people, which make up most of our people, because cancer is usually a disease of age. So for many, many years, physicians and scientists have been trying to come up with newer treatments that, first of all, are more effective, second of all, more tolerable, and don't have those undesirable side effects of chemotherapy.
So just to go back for a second, when we have an agent, which we call a chemotherapeutic agent, once it's in the body, whether it's through an injection or a pill or whatever form, it somehow recognizes to a large extent the cancer cells. And then what, what does it do to them? Is it destroying them? Is it working on some protein? I'm sure it's different for different chemotherapeutic agents, but broadly, what's the concept?
So with traditional chemotherapy agents, what people typically have in mind about chemo, it really doesn't recognize cancer cell and normal cell, and that's part of the problem. It basically interferes with cell division, with cell growth. Some of them target DNA, and when cells tries to make copy of its own DNA, they interfere with that process. They damage the DNA. Some of them target proteins that are required for cell growth, and but they really, our traditional chemo wouldn't really care whether it's cancer cell or normal cell. They would travel everywhere in the body, and whenever a cell is dividing, it would basically attack them. Just the general toxin for cell growth. And that's why we have some of the side effects with traditional chemo. For example, people get a lot of stomach symptoms, sometimes diarrhea, sometimes like their taste doesn't work so well. They're not able to taste food, because these are all cells that grow rapidly under normal circumstances. The taste receptors in the tongue, they are affected by chemo. For hair loss, for example, because hair is something that is constantly growing and the cells are dividing, so they are affected by chemotherapy. And bone marrow itself, for example, people are getting chemotherapy for some other cancer, for lymphoma or colon cancer, but they get anemic as a result of chemo, because traditional chemo didn't really recognize normal cell and abnormal cell. It would attack anything that's growing rapidly.
And the whole premise of that was that because cancer cells divide fairly rapidly, by giving certain drugs which would prevent that rapid growth of cells, it would arrest that growth. But like you said, the price we pay in the process is that normal tissues, which we need the cell division, whether it's hair or stomach lining or whatever, that doesn't happen, and we pay the price for that in an attempt to do something. So it's collateral damage, which is kind of taking place at the same time, right? Now, so I'm assuming that, like anything else in medical research or in any other area, the whole goal and effort would be to find ways in which you can target that treatment and somehow allow these agents to recognize the cancer cells and not impact everything else around it, or minimize the collateral damage.
Exactly, exactly. So, for example, let's talk about lymphomas, one of areas of my expertise because I focus mostly on blood cancer. Um, One of the most common forms of lymphoma, we have more than 40 types of lymphoma, but one of the most common types is something we call B-cell lymphoma, diffuse large B-cell lymphoma. And in the past, we used to give chemotherapy, and in some cases, it was enough, it would cure them, but in many cases, it was not enough. So around 20, 30 years ago, a new drug came to the market called Rituxan, and it identifies a protein on the surface of these B cells. Now, all B cells have this molecule called CD20, but it doesn't, it's not expressed, it's not on the surface of any other cells. So the effect of this antibody, that this drug that recognizes this molecule, is just limited to the B cell. So it makes it much more tolerable, very, very tolerable. And what it did was that it would use the immune system, it would guide the immune system to destroy those cells. So it increased the efficacy of our treatment dramatically. Now, still, with our traditional treatment, even with rituximab, we are only able to treat like 60, 70% of these cases. The other either don't respond or relapse. And still, a lot of patients are not able to tolerate our treatment. So still, it was far from ideal. Now, in the past few years, there have been a lot of progress using other forms of immunotherapy for these B-cell lymphomas. One of them is CAR T, which some people might have heard about. It's a very hot topic. And what CAR T is, that they harvest patients' own immune cells, a form of immune cell called T lymphocytes, and they train it basically with genetic engineering. They train it to recognize these cancer cells and destroy them. And it has had a dramatic efficacy in basically curing very refractory cases that in the past, basically, we really didn't have any effective treatment, and their life expectancy was very limited, few months. Now we are able to cure many of them.
So let me just parse this out a little bit. Within the newer modalities, I know we started talking about immunotherapy, and I'll kind of get into that in 1 second, but are there also certain chemotherapeutic agents without the help of the immune system can go and target a cancer cell more specifically than all the other tissues around it? Are there such options available now?
Yes, yes. For example, there are new drugs, and they are basically antibodies or proteins conjugated or linked to a toxin. But what it does is that instead of just injecting the chemotherapy or the toxin into the blood and let it go everywhere and affect every cell, we link it to a protein that can recognize cancer cells. So it would be like a targeted missile or a smart missile that would go in the body. That protein will attach to a cancer cell, and that chemotherapy that's attached to our protein or our antibody, that would affect only that area, that cell that's recognized by this drug. So it becomes far more targeted. That's one form of the treatment that has come to the market. There are other forms of targeted treatment that basically they are designed to target proteins or mechanisms that cancer cell use to survive and grow and evade basically death. In case of leukemias, for example, each cell in our body has internal mechanism that basically tells it to go away or die when it's not needed anymore. And some cancer cells express too much of a protein that enables them to evade death, basically, to resist this mechanism. So we have there are new drugs that we use in case of leukemia, such as venetoclax. It's a pill that people take at home that inhibits this mechanism, so the cancer cells cannot evade this programmed cell death and basically start behaving more like normal cells and die.
So I'm kind of just trying to visualize how the researchers in this field try to find such treatments. And so it seems like they look for proteins which are being produced by these cells, like you said, and the cells are the cancer cells, and the cancer cells are dependent on these proteins. And then they try and figure out a way to knock these proteins off. So almost nutrients. So the cancer cell, in a simplistic way, needs certain nutrients to survive and grow. And if you can't directly go after the cancer cell, but because the nutrient is floating around in the blood, if you can identify those and you can go and knock them off, then the cancer cell kind of loses its nutrition. So so are there only blood cancers which have solutions like this, or there are other cancers also which have similar kind of treatment available now?
Oh no, I mean, past few years have been very exciting times in oncology, both for blood cancers and solid tumors. So no, fortunately, in many cases in solid tumors, we have had, for example, in case of melanoma, lung cancer, immunotherapy has revolutionized the landscape. Also, targeted treatments that we have had for some other forms of cancer, such as liver cancer or colon cancer or breast cancer even, has really given us many more options. Some of them, sometimes it targets proteins that cancer cells need to use for their division. Sometimes it inhibits cancer cells from making new vessels.
So Dr. Kazemi, I'm just going to interrupt you. So we're going to be going on a commercial break on the air.
Sure.
In a few seconds. So folks, you're listening to EBC Radio. We're also live on live.heartbeatradioshow.com, live.heartbeatradioshow.com. We'll be continuing live on YouTube, but we'll be going off the air for a few minutes for a commercial break. So stay tuned. We're also live on the air on ebcmusic.com. So folks, continue to listen. We'll be right back after this commercial break.
EBC Radio would like to thank St. Peter's Healthcare System, treating you better for life, for sponsoring the preceding program of Heartbeat Show.
Exceptional times call for exceptional care, and once again, St. Peter's has been recognized.
So let me see. Yeah. You can still hear me, right?
Yes.
Okay. So for anyone listening on YouTube, we're still live. So we'll do a quick recap while we are on the commercial break on the radio. So it's somewhat of a crude analogy of sorts, but I think it kind of makes the point of the grass and the weed. So you have the weed kind of growing all over, and you take a chemical which destroys everything, and then you not only lose the weed, but you also lose the grass around it. That's kind of our generic chemotherapeutic agent we had. But what you are saying is that there is a lot of advancement where you're trying to see if we can just target the weeds and not damage the surrounding grass. And there are two kinds of products, as I understand it, as a non-oncologist. One is where we're using a target just on the weed itself or the cancer cell itself, or with the help of other proteins. And then the second part we're going to discuss a little bit more is using our immune system to help. So in the first instance, it's just the chemical kind of doing its job, and then the other instance is going to be the immune system. So as soon as we come back from the commercial break, what I'd like to do is help people understand what the immune system is, how it traditionally works for infections and all, and maybe it might be interesting if we can, if there is some history to this as to how somebody came around to figure this out, and then kind of understand. I'm sure these are exciting times in oncology. I remember in cardiology, we've gone through in the last 30 years from when I was starting out with really struggling with somewhat bigger crude balloons. We couldn't really do as much as we can do today. And in the last 30 years, it's just been so gratifying with the amount of work we can do with we can help our patients with.
Yeah, absolutely. Absolutely.
Maya Fine Jewels से order किया है. They make their own diamond jewelry in India since 1975. Making pricing in America, top quality diamonds, mom, at Indian prices.
That's right. Maya Fine Jewels lab certified diamond jewelry is now online. Shop at mayafinejewels.com or visit their showroom at 1315 Oak Tree Road, Islin, New Jersey.
Are you or someone you love having trouble getting pregnant? Uva.life is the answer. Uva can help you understand your fertility in the privacy of your own home. Log on to uva.life for more information. Use the code EBC Radio to get 10% off your first order. Uva.life. Now you, your body, and your doctor can all have the same fertility conversation. Uva.life. OOVA.life. Uva, the fertility translator that fully illuminates your fertility, giving you the clearest mind and steps for conception.
A message from Patel Builders, your heating and cooling specialist.
Are you looking to replace your heating or cooling system? Call Patel Builders. Feeling cold draft in winter? Call Patel Builders to add more insulation. Want to reduce your heating and cooling bills? Call Patel Builders at 732-701-7015. Again, 732-701-7015. Get up to $4,000 in rebate and up to $10,000 in financing at absolutely no interest to New Jersey Clean Energy Home Performance with Energy Star program. The Home Performance with Energy Star program is brought to you by the New Jersey Board of Public Utilities and its Clean Energy program. Call Patel Builders for repairs or to replace your heating systems. Call us now at 732-701-7015. Again, 732-701-7015.
Patel Builders, we also offer maintenance and repair services.
This part of the program is brought to you by St. Peter's Healthcare System, treating you better for life.
Welcome back, listeners. You're listening to EBC Radio. This is 1170 AM. Program is Heartbeat. Heartbeat is an educational program which airs on EBC Radio every second and fourth Saturday of the month. I'm Dr. Dinesh Singal. I'm an interventional cardiologist, and I'm joined today by Dr. Hossein Kazemi. He's an oncologist with Astra Cancer Care, and our topic today is discussion on the new advancements in cancer care. So we thank you for joining us. The phone number in the studio is 732-297-9886. We're also live on YouTube now, so our future programs in most cases will be also live on YouTube. So you can always go to live.heartbeatradioshow.com and listen to us and watch us on YouTube. and the recorded shows will also be there. On the air, you can listen to us on 1170 AM or on the web, ebcmusic.com. So Dr. Kazemi, thank you. We were discussing some of the new advancements, and we talked about some targeted chemotherapy. And now I'm wanted to help folks understand this whole concept of immune system and how it's being used to help with cancer treatment. So first, just in general, our immune system, we know, and now with this whole pandemic, is, there's more awareness of it, is largely there to help us treat foreign substances. And in most cases, they are viruses and they are bacteria. Now, cancer cells are also not normal cells. So
Exactly.
in general, why isn't our immune system by itself able to recognize these cancer cells? What's different about these cancer cells? Why can't it just go and knock those cells out when they grow?
That's a very good question, and the whole field has been trying to answer that question for the past 50 years. To be fair, our immune system does a good job of killing a lot of cancer cells. In our body, even like completely healthy people walking around each day, there are cancer cells that are produced. Even healthy people develop a lot of cancer or cancer-like cells, but before they even notice it, before it grows and causes any problems, it is eradicated by the immune system. So a lot of these cells, a lot of these would-be cancers are destroyed by the immune system. Some of them somehow figure out how to evade our immune system. These cancer cells are crafty. Our normal cells, they have these signals to tell the immune system that, hey, we are part of our normal body. We are basically self. Don't kill us. Cancer cells are able to use these signals to evade the immune system and basically sometimes exhaust the immune system. So that has been the basis for some of our immune therapy that we use, say, in melanoma or lung cancer. Basically, it kind of interrupts this signal. We use proteins that comes between the signal, the don't eat me signal or don't hurt me signal expressed by a cancer cell, and the immune system. Interrupt this signal so the immune system can do its own thing. Some of the drugs that are these days, many people know them, like Keytruda, Opdivo. These sort of drugs are basically, they work this way.
It reminds me of a war movie or the soldiers going in the jungle and camouflaging themselves.
Exactly.
You can't distinguish them from the greenery from what they're wearing. And,
exactly.
And unfortunately, it creates a problem for us. So how? So now, somehow, in order to use our own body's defenses, we have to tell the immune system that, hey, this cell is really not part of us. Because logically, unlike the broad chemotherapeutic agents which go in and stop cell division, but they're indiscriminate, they stop cell division all over the body and create all the side effects which they do. If somehow our own immunity or immune system can recognize in a very controlled fashion that these cells are abnormal and they can selectively go and knock those out, that would be a lot more, or would cause a lot less side effects, right? So I would assume that that's the premise of using our own immune system. So how is our immune system trained, or in the options which are available today, in order for that system to recognize? How do you tell the immune system that this is not the right cell and therefore it needs to be knocked out? How is that brought about?
So sometimes just disrupting that camouflage signal is enough. Sometimes no. We need to basically be much more direct with the immune system. With the help of genetic engineering these days, we can train our immune system. Basically, instead of waiting around for the immune system to recognize some abnormal protein or cell, basically give the cells the manuscript. Tell them, hey, this protein, abnormal, get rid of it. And the way it works is that we basically harvest the immune system. And it's done by hooking people up to a machine, get a little bit of their blood, separating the immune system. Similar to blood donation, really.
Mm-hmm.
And then those cells are shipped to a lab. Genetic code is inserted to those cells that basically tells them to target these specific protein. And we choose a protein that's found on the cancer cells and not on many normal cells. And then they grow the cells and then they inject it back to the patient. And this method has had tremendous success for some of cancers, mostly blood cancers. This method that we use is called CAR-T, chimeric antigen receptor T cells. But it has had a dramatic success. And the thing about this treatment is it's basically like a living drug. These cells survive in the body, and then after initial destruction of the cancer cells, they continue their surveillance. They persist around basically. In many cases, basically cure the patient for good.
So once those cells are taken out, how long does it take for them in the laboratory setting for them to get cultured and grow to a certain amount that they can be injected back? What's that period?
So with the advances that we have had, they have reduced that duration to around 2 to 4 weeks, which much better than before. Still, sometimes it's too long for a patient. If you have an acutely ill patient, sometimes they can't even wait 2 to 4 weeks to get this treatment. For this reason, they have come up with even a simpler way, much faster way, and that's using what we call bites or bi-specific proteins or antibodies. And what it is, it's basically like a bridge, and or a linker, and one side of this linker attaches to a cancer cell, the other one attaches to the immune cell, and kind of pokes the immune cell, hey, look what I brought here for you. And basically it kind of annoys the immune cell enough to start killing the cell close to it. So this one is basically like a regular drug available off the shelf. It doesn't require this long production process.
You're listening to EBC Radio. This is 1170 AM. We're also live on YouTube. It's live.heartbeatradioshow.com. And we're talking to Dr. Hossein Kazemi, and our discussion is revolving around advances in cancer care. The phone number in the studio is 732-297-9886, 732-297-9886. So when it goes to the lab, I'm assuming they have sophisticated instruments for them to tell that, okay, X number of cells have grown, and then they can be brought back. And
yeah.
And so from a very practical standpoint, is your office calling them every day? Well, are the cells ready? Or the lab tells you, guys, we have enough now, we can send it back. How's that work from a very practical standpoint?
From a very practical standpoint, sometimes I do annoy them by emailing them. Are we there yet? Are we there yet? But they usually tell us beforehand that we will have the product ready for you in 2 to 3 weeks. and it requires a special delivery process. Of course, these are because these are live cells. It's a little bit different from injecting just a simple chemical to the body. So it requires basically a little bit more sensitive handling. There are several types of these CAR Ts around. 3 of them are approved by the FDA, and 2 of them require actually like hospitalization for giving it to the patient, because they need to be monitored for several days after this infusion. And one of them actually has a little bit a smarter design, shall we say, and it can be given outpatient because the side effects are much less severe. And that's the product that we use, Lysacaptogen is the name. And that's the product we use. So we actually infuse it in the body and infuse it in the office, and then the patient can go home.
So most of these infusions are just intravenous?
Yes, exactly. Patient just comes, get intravenous infusion, and then they go home.
And are they generally well tolerated?
Generally, yes. But these immune cells are very potent. Sometimes when we infuse them, when we infuse them, they start proliferating because they have been trained in the lab to recognize these cancer cells and destroy them. Now, when we infuse it in the body, then they see a lot of these cancer cells around. So they get excited, they start proliferating and destroying these cancer cells. And it can cause an inflammatory process, what we call cytokine storm, which can happen in any time that immune system is very, very excited. Can cause basically, sometimes it feels like a severe flu, sometimes it's even more severe, can cause low blood pressure, and people need to be admitted to the hospital for support with fluids, with medication to bring up the blood pressure, with steroids. Initially, several years ago, when these drugs were first marketed, this was tricky. Sometimes it was hard to control. Over time, we have learned how to best control it. And these days, we are very, very good in managing these symptoms. Some products have a little bit of more this side effect. And that's why some of these products, such as they need administration in the hospital, because people need to be monitored closely for the first week after infusion. Some of them, they have tweaked the production process, so it's much smoother. So it doesn't, the prevalence of these severe side effects are much lower. And they can be done in an outpatient basis. And that's actually the reason that our group chose that specific product, Lysacaptogen, for B-cell lymphoma, because it's much easier for the patient. That being said, it's generally well tolerated. So sometimes a lot of patients who are older and couldn't go for intensive treatments, such as bone marrow transplant and etc., we can easily get them through this CAR T treatment.
And is it usually one infusion, or you need multiple infusions?
No, fortunately, it's usually one infusion, because these are this is a living drug, and for the first time in medicine, we have a living drug that replicates inside the body. So it's one shot and done.
And you mentioned B-cell lymphoma. Is that the only tumor which you can address by these means, or there are some other cancers which also can be impacted?
So right now, it's only FDA approved in B-cell lymphomas. They are trying it in many different cancer types. In, for example, ovarian cancer, breast cancer, lung cancer. It's in earlier stages of development, and and even in some malignant condition. Basically, it can be used to attack anything in the body. For example, even in conditions that cardiac fibrosis is a problem, they are using these CAR T cells to sort of clean up and destroy that fibrosis. Basically, the hope is that as we get better in training these cells, it can go and get rid of anything that we don't like in the body. But it's in those conditions, it's in very, very early stages. So we have to see how well it works in those conditions.
So how many years has this CAR T treatment been available now, ballpark?
So if the first FDA approval roughly 3-4 years ago, but it has been a very long process. The basic idea of it actually goes back to 1990. And it took them 21 years to tweak it enough, and basically the engineering process took 21 years to get to a point that for the first human trial. From first human trial, then it took like 5-6 years for FDA approval, and it has been around for 3-4 years roughly.
And in the last 3-4 years, other than learning how to manage the side effects or the ability for the patient to tolerate it better, have you seen any changes in the way the product is developed so that it makes the tolerance and efficacy better?
Yes, absolutely. So the first products that were tested and marketed, basically they took whatever T cells were around and engineered them and basically then return it to the patient. And but the latest product that was actually FDA approved a few months ago, for example, it uses a certain number of each T cell subtype, so it makes it much more tolerable. They are also using other targets. For example, training these T cells to go after 2 or 3 different targets on the same cell. So this way, the hope is to make it much more effective. Because right now, the success rate for relapsed refractory lymphoma is around roughly 40% of people who were relapsed and refractory to everything else. We can cure them with this CAR T cell. The hope is to make it even more effective, basically by training to go after, say, 2 targets on the cancer cell instead of 1 target. This way it will reduce the chance of resistance to treatment.
So are there certain either patients or cancers where when they come to see you, the only treatment you will think of is immunotherapy, or immunotherapy is in most cases an add-on to other therapies?
Immunotherapy, I mean, right now it includes like several categories. For example, these CAR T cells or something like Opdivo Keytruda that we mentioned before. For example, melanoma these days, a lot of times the upfront treatment is can be immunotherapy alone. For certain subtypes of lung cancer, in certain cases, we could do immunotherapy, but in majority of cases, immunotherapy is an add-on to chemotherapy. And sometimes we use it alone, say, in bladder cancer or even kidney cancer. So it's a very exciting field, sometimes alone, sometimes in combination. Many decisions go into it, whether we combine it with chemo or use it alone. It depends on cancer type, how much the patient can tolerate, and disease burden and such.
Now, obviously this is still a moving target, and I'm sure there are more advances which are in the pipeline. If knowing what you know in terms of what advancements and what research is going on, is there some way to project if there is going to be a major change in how you do things in, let's say, 5 years out or 10 years out? What's the future hold for all this?
Oh, absolutely. In terms of blood cancer, I would say these immunotherapies are going to be moved to first line and probably decrease the role of chemotherapy. Right now, these immunotherapies, these CAR T cells or bispecific antibodies, CAR T is used for relapse or refractory lymphoma, and bispecifics, we are testing in relapse and refractory. But the idea is to basically move it to use it in newly diagnosed patients and try to minimize use of chemotherapy, because a lot of times our elderly patients have hard time tolerating these chemotherapies. As you know, a lot of times because of heart problems, for example, they cannot tolerate chemotherapy, or in general, other problems. So for example, in our center, we have a clinical trial to use one of these new immunotherapies, one of these bispecifics or linkers in the first line, basically to reduce chance of relapse. So hopefully the patient will never relapse and require a CAR T. They are using it in elderly people who cannot tolerate harsh chemotherapy, basically to treat the lymphoma with immunotherapy alone or with minimal help of chemo. So I think that would be a major advancement for our elderly patient. And we are actively participating in trials basically to help make these advances happen in our group. Similarly, in other cancers such as myeloma, which we have had a lot of advances, but still not a curable disease, I believe these CAR Ts, one of them just approved, will move to frontline and decrease the role for old school chemotherapy. It will take time, but I believe it's something that will happen in the next few years for sure.
Well, Dr. Kazemi, this was extremely instructive. I learned a lot, and I'm sure our listeners have learned a lot. So I thank you for taking a time on this Saturday afternoon to be with us and educate our listeners. Thank you so much.